So for everyone out there, this is going to be a pretty straightforward introduction to the issues surrounding the disease process of carotid stenosis in the context of the need to revascularize carotid stenosis for either asymptomatic or symptomatic lesions. So we'll try to start from a pretty basic level. It may be too basic for you, and if so, we'll hopefully get to some more interesting things in a few slides. But with that introduction, here we go. Everybody hearing me okay, I assume? All right. All right, so what is the epidemiology of carotid stenosis? So interestingly enough, about 8 to 15% of ischemic strokes are attributed to atherosclerosis of the carotid artery. Back in Lancet in 2014, there actually is a really interesting article that showed that actually whole body scans of mummies and pre-industrialized hunter-gatherers with well-preserved cadavers had evidence of atherosclerosis in about, I don't have it on here, about 30% of the general population even back then. So this is something that predates our current eating habits and food preparation, some would say excesses. It's certainly something that's been with us for a long time. One current study showed that about a third of individuals that had never had any symptoms between ages of 40 and 54 years had ultrasonographic evidence of atherosclerosis in the carotids. So that's roughly your prevalence, like right in the middle years of 40 to 54. About a third of people have some degree of carotid atherosclerosis, which is pretty prevalent. So obviously we have some basic carotid anatomy here. So the carotid artery is a paired cervical arteries. There's one on the left and one on the right, obviously. And its job is to irrigate the anterior circulation of the brain. So just to start off with some basic anatomy, roughly normal anatomy and how do the carotid arteries arise. So I will try to quiz the audience. I don't know if that's going to be successful or not. Let's see here. Maybe not. I don't see any way to see answers. But so you have your aortic arch here. If anybody just think in your own mind, what is this artery here? The first branch. So that would be your innominate or your brachiocephalic artery. It provides the supply to the right arm, as well as the right carotid artery and right vertebral artery and shoulder. This first branch is the common carotid, subclavian. And then up here, the next order of divisions would be internal carotid artery that traverses to the brain, and then external carotid arteries, which branch in various patterns. Maybe it may be flipped here, actually. Yeah, maybe this is external here and the internal here, and same thing here. And then over here, you can actually see this is considered a normal anatomy. You actually see a little bit of atherosclerotic disease here on this patient's left internal carotid. This is what a carotid bifurcation looks like on an angiogram. So we're looking at a roughly AP, but a little bit of an oblique angle. You can see someone's teeth here. The nose is probably just off the screen here. The lower portion of the jaw, cervical spine. And this is an injection into the common carotid artery, and then the division into the internal carotid, which traverses up through the petrous bone to the skull and into the brain. And then the external carotid artery and a series of branches, which are named and we won't go into here, but are interesting fodder for medical student questions. So the major branches, the internal carotid artery, this is an anterior view here. And this is unique in that you can actually see both carotids going to the brain and both sides of the anterior circulation at the same time via someone that had a carotid occlusion and they injected, we were able to push dye through the entire anterior circulation when they injected via this tip of this catheter here. The major branches are the ophthalmic artery, which supplies blood flow to the eye and the intraocular structures. Very commonly have a posterior communicating artery is next. These are all intracranial vessels. There's some extracranial vessels as well that aren't covered here. The next branch up is the superior hypophyseal artery, and then the anterior cerebral artery, which is here, and then the middle cerebral artery, and that's your basic anatomy of the intracranial arteries. Let's see, not moving. There we go. All right, so this is a AP and then lateral angiogram of a patient that I saw recently who had carotid disease. And so this is the AP view, and you can see the internal carotid artery is kind of overlapped with the external carotid artery, but you get the sense of this irregular mountain-like slash bite out of the side of the blood vessel here, which is an atherosclerotic plaque, which is ulcerated, encroaching on the lumen of this patient's proximal carotid artery on the left. And this is the lateral view. So you can see an external carotid artery here, which is mildly stenotic. And then again, a very ugly looking ulcerated, irregular plaque encroaching on the normal lumen of the internal carotid artery here, resulting in about 65 to 70% stenosis. So this is what we often face in this disease process. All right, to go back to the basics about atherosclerosis and blood vessel anatomy. So just basic blood vessel biology is that these artery wall has 3 layers: the tunica intima, which is really just an endothelial layer, a very thin but important layer that is the interface with the red blood cells and the intravascular cells that are circulating. It's a thin layer of connective tissue. Tunica media, which is the more middle portion here. Elastic and smooth muscle mixed in there, provides much of the elasticity and contractile component of large blood vessels. And then the adventitia, which in this slide is stained blue, which provides a lot of the tensile strength to resist dilations and fusiform aneurysms and that type of thing. And those can grow when this is violated. Also, the blood supply to the artery itself is in this region as well, the vasa vasorum. So what happens when you have an atherosclerotic development in a lumen of a vessel? So it's a disease of the arterial wall, and it starts at certain, often stereotyped, susceptible sites in the major conduit arteries. I mean, the obvious ones are arteries of the legs, coronary, carotids, and even to some degree intracranial. And so you have an evolution of something called a plaque, which is a buildup of fatty cells that is then layered upon by inflammation reaction in the vessel wall itself. So in this slide, you have a normal intima, media, and adventitia. And then on this side, you have a lipid-rich accumulation of cholesterol type lipids in the vessel wall here. And then you're going to have a fibrous cap eventually form as a secondary to long-standing inflammation. And this is a bit more of an advanced one, a larger lipid-rich core and a thinner fibrous cap, which is continually trying to layer new layers of fibrous tissue over it to protect the vessel lumen. And often when you have a plaque rupture, this fibrous cap breaks and you have a violation of the intima with blood cells that are passing by being exposed to the lipid-rich necrotic core, thrombus forms, and you have strokes. So that's generally how this progresses to become symptomatic. So what happens early on? First of all, you have an early fatty streak development. This can happen as early as in childhood, just slight changes in the vessel wall. Then you can have an early fibroatheroma in your teens and into your 20s, advancing into a true atheroma, which is more like what you see here. Over the age of 55, and you can advance further into complex lesion development with necrotic areas, calcifications, and areas that are prone to rupture. So this is just like a little bit of a graphical representation of that. So it's showing the intima, the endothelium, the media and adventitia, smooth muscle cells, etc. Early atheroma. You have this enlargement where this becomes vulnerable. You can have a rupture in the plaque, which then clot forms. And, or you can go from this to a more stabilized plaque where you have a lot of scar buildup and fibrous buildup protecting the vessel lumen from the atherosclerotic necrotic core. And then even that, though, can eventually develop into this complex situation where you have a small lumen and flow restriction leading to ischemia But the most common type of ischemia is this one, where the plaque ruptures, clot forms, and there's distal emboli. All right, how do you screen for asymptomatic? What are the guidelines for this? There's some basic screening modalities that we use. The most common one being carotid duplex ultrasonography. Other ones that are also common include CTA and MRA, a little bit more advanced imaging, and costs a little bit more. But the carotid duplex is the workhorse of screening. So what are the indications to screen patients? There are certain patients that have the disease and elsewhere, which are higher risk of developing carotid stenosis. For example, patients with peripheral arterial disease. Interestingly enough, we don't look at this as much anymore, but one of the ways they used to pick up prior to good imaging symptomatic stenosis or asymptomatic stenosis was looking in the retina at the arteries for little cholesterol deposits that are being lodged from emboli from the neck in the retinal arteries. Those are called Harlan-Horst plaques. If you see those plaques, you have about a 13% chance of having some significant carotid stenosis. If you happen to have a Harlan-Horst plaque plus a bruit on auscultation, you have about a 37% chance of having a greater than 50% carotid stenosis. Patients that undergo coronary artery bypass graft surgery have had screening studies that show about 38% of them have significant, over 50% carotid stenosis. And in patients that have atherosclerotic abdominal aortic aneurysm, similarly are reasonable to be screened. And there's even more advanced screening criteria, which I don't want to go into here, but they have a long list. If you have 2 or 3 of the various risk factors, hypertension, diabetes, et cetera, then you're reasonable to have a carotid screening study. All right. What happens if you have a symptomatic patient? So similar imaging modalities in that case. In the gold standards is angiography if you want to truly understand the degree of stenosis and what's going on with the plaque as far as ulcerations, thrombus layering, and all these types of things. CTA and particularly MRA have some advanced capabilities that are becoming closer and closer to being standard in many centers that may help us understand this without angiography, inflammation and the carotid cores and clot in the center of the plaque, et cetera. But right now, still angiography is for sure for degree of stenosis is the gold standard. And then of course, if you want to look for strokes in the brain as a result of something that sounds like stroke-like symptoms in this presence of carotid stenosis, MRI is the gold standard there, and CT is also an option if the patient can't get an MRI. All right, this is just a quick case to get everyone thinking about how this might work in patient care rather than in slides. So I kind of alluded to this one earlier. 50-year-old male with high blood pressure, diabetes, had sudden onset difficulty writing with his right hand. I believe he had a pacemaker, so he couldn't get a MRI. So he had this CT scan of the brain. And to jump to the chase, he has several distal embolic infarcts in the MCA-ACA bordershed territory upstream from this lesion here. So this would categorize as a symptomatic carotid stenosis. And of course, the question is, what do we do with this? Put them on blood thinners, send them home, do surgery, do stenting. So that's all the things that we'll get into partly in my block and in other blocks. Looks like someone raised their hand and that flashed up, but I can't see the question. Oh, here, maybe up here. Okay, if anybody knows how I can see that question, someone that raised their hand, I'm happy, I'm all ears. I don't see it in the question and answer section. All right. Sorry if you raise your hand, I don't know how to engage you. And the answer to that question is what is the natural history of these problems? So what happens if you do nothing? And that is, let's understand on the other side is what happens if you intervene, and which one of those would benefit the patient in different situations. So to understand this, there's like some pretty good randomized controlled trials that have become gold standard on how we manage these patients. And those trials were randomized controlled trials, so they had a control arm. So we can look, here we go. Yeah. I'm looking at the chat as well, so if you guys chat with me, I can stop and talk, answer questions. All right. So some of these trials, like one called NASCET, compared best medical therapy to surgical carotid endarterectomy. Same thing with ECST, the European Carotid Stenosis trial. Asymptomatic trials, ACAS, American trial, European trial, asymptomatic patients with carotid stenosis. So the question is, what do you do with someone that has symptoms and has carotid stenosis, and what do you do with someone that's not symptomatic but has significant carotid stenosis? And so we'll talk a little bit about what to do in those different situations. So for instance, this is the natural history of patients in the NASCET trial who had 70 to 99% stenosis and were symptomatic. In the European trial, 80 to 99%. All right, this is time in months, so up to 2 years here. And this is freedom from ipsilateral stroke. So 100% is good, lower you go is bad. So you can see this is the medical arm here coming down, and this is the treatment arm. So we can get some information about what happens to patients that are medically treated in these symptomatic trials by watching these lines. And you can see the medical arms. The asymptomatic patients did far better with medical therapy than their symptomatic counterparts in the two control groups. So this makes us understand that the natural history, what happens if you do nothing and just treat someone with medical therapy, is far worse for patients that are symptomatic than asymptomatic. So that's a core thing to understand because it informs what we do with treatment. For example, symptomatic strokes. How many people that have had a stroke and have a same side carotid stenosis have another stroke? So in the NASCET trial, 13% of patients had a repeat stroke, major ipsilateral stroke at 2 years after randomization. At 13% per year, so 26% total over the 2-year time frame. The European study had 16.2% for any stroke on the same side at 3 years. So their data was a little bit better medical-wise than this one, but 26% in the next 2 years is a very high number. Additionally, when it comes to symptomatic lesions, how risky they are is actually predicted by how narrow the vessel is. And most strokes occur within the first year, even though these studies went out to 2 and 3 years, respectively. So what do we mean by the stroke risk is affected by the degree of stenosis? So this is a table here looking at severity of stenosis up to 99% from 60% in NASCET, and then the other trials. We'll focus on NASCET for now. You can see as you go higher degree of stenosis, you generally have a higher degree of 2-year stroke rate. And this also holds true in the European studies. But in the asymptomatic study, there was not quite that association found. So this is why the degree of stenosis is a little bit more significant in our minds than in the asymptomatic patients. What is the risk after a TIA or a stroke in symptomatic patients? And so a large number of these strokes actually happen pretty soon after the initial event of a TIA or stroke. You can see about 5% in the first 5 days and up to in the low teens within 30 days of a repeat stroke. So that's why we don't generally send someone that's just had a small stroke from carotid stenosis from the hospital and bring them back and to clinic and then talk to them and then book surgery. they typically get some sort of intervention for stroke prevention in the same hospital stay, and it's for this reason. It's because the highest risk of stroke is early on after your initial symptomatic event. And this looks like, when you're going a little bit further on the time horizon, so it looks a little bit more like this. This is the number of strokes saved per 1,000 carotid endarterectomies in patients with 50 to 99% symptomatic stenosis. You can see less than 2 weeks is the most benefit by far. If you wait 3 months, very little benefit. It's like we got a question. Yes, so how is the degree of stenosis evaluated is the question. So in NASET, in ACAS, I believe as well, they all had angiographic imaging with a catheter angiogram. In newer studies, they're relaxing this to be CTAs or angiography, and sometimes even MRAs and Doppler. But they make adjustments knowing that often CTAs show higher degree of stenosis than the angiogram does. And so there's an adjustment for that. So the degree of stenosis may be slightly different on a CTA to be included in a trial than on an angiogram. Hopefully that answers your question. All right, so that's symptomatic. So that's a home run to take care of a symptomatic patient with a carotid intervention for stroke prevention. What about asymptomatic patients? What's our evidence? What do we do if you have an asymptomatic patient that turns out has 70% stenosis, and then you're in your clinic? So asymptomatic patients in the ACAS, which is the largest asymptomatic intervention randomized control trial to date, is greater than 60% stenosis was what they decided was the degree of stenosis that made you an asymptomatic patient that could be included in the study. The ipsilateral stroke rate in that medical arm, and again, this is back in '95, before we had out some of the more advanced medications we have now, the degree of stenosis was 11% over 5 years. I'm sorry, the stroke rate was 11% over 5 years. And that's significant, but it's pretty low. That's barely 2% per year. So this is this group up here that is coming out to 2 years with very little in the way of strokes. In addition, you see that over time, since '85, all the way out here to the mid-2000s, you see that there's like a trend toward decreasing ipsilateral stroke rates in patients with over 50% asymptomatic carotid stenosis treated medically. And so this, for example, here was ACAS that we just talked about, NASET, and then as you get closer and closer to current days, seems like the medical arms of these trials, the stroke rate is decreasing in asymptomatic patients. So that informs what we do with asymptomatic patients, because what eventually may happen if medical therapy truly does show to be beneficial at decreasing stroke rate enough, it may actually decrease it to be better than the stroke rate of the surgeries that correct it. So that's something that's actually being investigated currently in a randomized trial, which we'll talk about briefly in a second. All right, so you choose to medically manage a patient with carotid stenosis. What does that medical management look like? So the mainstay of this is risk factor modification, as well as some other medications for intervention. So one of the main things is aspirin has been shown to reduce the stroke rate in patients that have had recent TIAs or strokes and carotid stenosis. There's no consensus whether an aspirin 81 or 325 is better than the other. The AHA has some guidelines that does not recommend dual antiplatelets routinely for patients with carotid stenosis due to bleeding risks. The next big class of drugs, which has come along since those studies were done in '95, is statins, which work in an interesting way to block cholesterol from the liver. And they have been shown to not only help prevent strokes, but also in some cases even to reduce the size and degree of stenosis and atherosclerotic plaques, particularly in concert with calorie restriction and dietary modifications. In one study called the Sparkle trial, which was a trial that gave patients statins after they had a symptomatic stroke, or TIA, demonstrated the reduced risk of stroke by 30% patients with known carotid stenosis, just giving them patients statin drugs. Smoking cessation is obviously extremely important in patients that are smokers. This is a great driver of inflammation, and it's very rare for me to see patients with symptomatic carotid stenosis symptomatic carotid stenosis that aren't smokers. It does happen, but it's very rare. So if the people are smokers, they got to stop that if they want to try and halt the advancement of the plaque. And also antihypertensives, the current HI guidelines are to keep patients who are asymptomatic, their blood pressure under 140. And then of course, there's all the usual things, dietary, exercise, etc. So asymptomatic patients and symptomatic patients are currently being enrolled, and this is a little out of date. I actually forgot to look up and see where they are now, but there's a trial called CREST-2, which I believe some of the future speakers will talk about all the different ways in which you can intervene and the evidence for that in carotid stenosis. But so currently there's two concurrent trials all being put under the banner of CREST-2. Essentially, they have two groups. One is a medical therapy group versus CEA for asymptomatic high-grade carotid stenosis, and a medical therapy group versus carotid stenting in tandem. And so they're going to have a medical therapy group, which includes aspirin at 325, and LDL driven quite low, below 70. And that study, that Sparkle study I quoted you, that had a 33% reduction in stroke rate in patients with carotid stenosis with statins, they were trying to get the LDL less than 100. So this is even more aggressive. And again, blood pressure less than 140. And I don't remember what SRF is. So that medical therapy versus CEA and medical therapy versus carotid stenting. And so they're going to find out two things from this. One is, what is the medical therapy stroke rate when watched over time with all the new medical treatments? Also, what is the complication rate of CEA, and is CEA have more complications than medical therapy? And at the same time, they're going to do the same medical therapy arm and compare the stroke rate and complication rate of carotid stenting to medical therapy. So we'll find out all of this for asymptomatic patients with high-grade stenosis, about 70% shortly. I think they're over halfway to target enrollment at this point. Let's see, I think there's a question. Let me see if I can find it here. Question is, in what situations would asymptomatic atherosclerosis be detected in a patient? So these are patients that have other risk factors that we talked about earlier. Coronary artery disease. Cardiologists commonly, when they know patients have coronary artery disease, order annual Doppler ultrasounds as screening tools. Once carotid stenosis is found, they often annually will have carotid ultrasounds. Other things will be, TIAs or other things that require blood vessel imaging that that detect incidentally carotid stenosis. Headaches, patients get a CTA of the head and neck for aneurysms or whatnot, and they found asymptomatic carotid stenosis. So there's a whole host of reasons. So the outcome of this study will be looked at will be composite stroke and death rate within 44 days of randomization, and any ipsilateral stroke to 4 years post-randomization. And I wanted to conclude here with just some take-home points that I had committed to memory when I was a resident, because we had an amazing resident conference every morning for an hour. And this topic came up commonly, and it gave you good points with the attendings if you knew these data. Not only that, but it's extremely helpful when making decisions about what to do with patients that you're consulted on, because if you don't know these data, then you don't know what to recommend. But these things guide our management even to today, even though some of the data is old. So for example, ACAS, which is asymptomatic carotid stenosis, that medical therapy was compared to carotid endarterectomy. That trial, 60 to 99% stenosis, asymptomatic. The stroke risk was, the patients were followed for 5 years afterwards for ipsilateral stroke rate. And the results of that study showed 11% stroke rate over that 5 years in the medical arm and 5.1% in the surgical arm. And there's a lot of detail that we can discuss about that, and I'll leave that to Peter, who I think is going to discuss these trials in the Journal Club. But just to give you a sense, that's where we come up with our justification to do interventions on asymptomatic patients between 60 to 99% stenosis, although medical therapy may have improved, and we'll find out when CREST-2 comes out. And this may have even flipped, we'll see. The absolute risk reduction from this study was 5.9% over 5 years. So that is worth committing to memory. Someone consults you for a patient with 69% stenosis. Generally speaking, if the patient is a reasonable, surgically safe surgical candidate, you can quote these data, at least until the next CREST comes out. Symptomatic carotid stenosis, NASCET trial. People quote this even to date. Compares CEA versus medical therapy for patients with symptomatic stenosis, 79.9%. They followed those patients for 2 years, and the ipsilateral stroke rate over the next 2 years in the medical arm was 26%, 9% in the surgical arm, with an absolute risk reduction of 17% over those 2 years. So very strong data to do CEA in symptomatic carotid stenosis patients. And again, I would like to emphasize that you need to do this early because the large burden of recurrent strokes are within the first weeks after the event. CREST, which we didn't talk about, so I'm not going to go into too much, but it compared, it's kind of a little bit more of a confusing trial, but it compared asymptomatic and symptomatic patients. It's the first CREST trial, and compared CEA versus CAS. And the take-home statement from that one was that there was no significant stroke rate, no significant difference in the stroke, MI, or death, the main endpoints between the two groups. And interestingly, the subgroup analysis showed, or the secondary outcome points showed that MI was higher in CEAs and ipsilateral stroke was higher in stenting. But there was no medical therapy comparison in that group to know how they fared against medical therapy, and it was also mixed symptomatic and asymptomatic. So it's a bit of a hairy one to untangle.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.